It always takes a hot minute. Okay, now let me just get this shared in a couple groups. All right, if you are already tuning in, drop a comment below. Let us know where you are joining us from today. I'll be going here in just 1 minute. All right. Okay, welcome everybody. Welcome to this month's TBI Talk with Dr. Perry Maynard. And since it is Brain Injury Awareness Month, I thought this would be a great month to chat with Dr. Perry about, some of the things that happen after a brain injury, what to look for in a doctor who can help you, and how Dr. Perry and his office, how they approach treatment with brain injury. So excited to have you here today. So let's just jump in. What happens to your brain when you have a brain injury?
Yeah, I think this is a great place to start because I think those will set the stage for what should be done, and understanding also too where different modalities fit in. Before we hopped on this conversation, we were talking a little bit about hyperbaric, which is a really cool tool that we use. But you start to look and say, well, okay, this person went to vestibular rehab, they did great. This person did HBOT, they did great. This person did an elimination diet, they got better. But it doesn't work for everyone. So how do you start explaining how cutting out, gluten and dairy helped one person versus, physical therapy helped another person? When we kind of look at what happens with a brain injury, when you look at what the research shows, a few different things happen. So one of the first things, and I always explain this to patients, that happens is if we think about your brain in the consistency, right? So our brain is mostly fat. And I think of the brain, so within the brain, we have white and we have gray matter. And these are different consistencies. And I kind of use the analogy of it's kind of like grizzle or fat on a steak. So how you cook a steak, and the meat and then the fat, and they're just two very different consistencies.
Mm-hmm.
And they slide against each other like that once they've been cooked. Mm-hmm. Think of the brain in a similar way where at different levels within the brain, you get different consistency. So anytime there is an acceleration or deceleration moment in the head, you can get what is called shearing of axons, right? Or axonal shear, right? So you get this movement within the brain. And this is where, when you look, you don't really have to hit your brain to suffer concussion. This is why things like a whiplash injury, or a fall on the ice, or you fall on your butt and it kind of shocks up your head, you really just need a force to be transmitted into your brain. And the more force that is transmitted can create more movement. And so one of the first things that happens is some of that axonal shearing. And so then when you look at symptoms manifesting from a brain injury, the question is, it's kind of like I always tell patients, like your brain has gone from high-speed internet to like AOL dial-up, right? So these super fast connections are now like beep, boo, doo, 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 right? This slow connection. Or if you ever played the game Telestrations, it's a really fun game where you have a word and say it's cat. You write cat, you hand your booklet to the person next to you and they have to draw a cat. And then that next person has to guess what that drawing is, and you go around the room and eventually you get back and you look at what someone guessed and you're like, how did you get that from cat, right? And that's kind of what happens, is that these networks within the brain can become disrupted. And so now maybe when an individual turns their head, they now perceive that as they're falling backwards, right? And so it's this mismatch. So that's kind of one way we can kind of think about what happens during a brain injury, is that circuits that are functionally connected become a little bit wonky. The other kind of things that occur with a head injury that are supported in the research are there becomes a change in energetics in the brain. So especially acutely or early on in a head injury, we know that brain circuits become very unstable, right? And this is why sometimes if a head injury is bad enough, you can see things like seizures. So that, right, so like if we're looking at a neuron, there's constant flux of sodium, potassium, calcium, all these different molecules in order to keep a neuron stable and to keep it firing stable. And so we know in a head injury that becomes unstable. So your ability to produce energy is not great. And this process can last anywhere from 2 to 4 weeks, and in some individuals, even longer. So kind of a similar analogy, it's like your brain has gone from being a fuel efficient Prius, maybe getting 40 miles to the gallon, to now getting 5 miles. So we know that brain injuries disrupts the energetics of the brain, right? So now we kind of have two mechanisms that we need to be aware of. And the third, I guess I'll talk about two more, is the next one is that there's changes in the immune system in the brain. So we know that there is, so within our brain, we have immune cells called microglial cells. We have M1, M2. Think of these as like the janitor or the cleanup crew. So like when you have a head injury, it's kind of like you threw like a party, right? And these microglial cells turn on to clean up some of the debris. But if you keep hitting your head and you keep throwing parties, eventually these microglial cells stay in the pro-inflammatory state, right? And so you have pro-inflammatory and anti-inflammatory. Both are good. No different than if I sprain my ankle. I want inflammation. Once the tissue's healed, I want anti-inflammatory immune cells to turn on to resolve the event. If I keep damaging my ankle, I'm going to become a little bit more hypersensitive in creating inflammation in that tissue. Same thing happens in the brain. The last piece is we know that cerebral blood flow becomes disrupted. And this can be another big reason for long-term post-concussive symptoms, right? So whether that be headaches, brain fog, dizziness, we know that cerebral blood flow gets disrupted. So this is not everything that occurs, but I'd say most often than not, these are kind of the four main things that occur from a mechanistic standpoint. And usually it's not just one, right? It's some aspect of all four of them. And so knowing that, the goal is to take one's symptoms. So we know in head injuries, a lot of people are dizzy, they have headaches, they're nauseous, but they can be for all different reasons. So one of the things is we want to be able to quantify as much of brain function as possible. So going back to that first thing that happens where circuits become disrupted, we want to say, how can we quantify everything from brainstem to subcortical to cortical function, right? So how can we quantify as much of brain function as possible? And we'll talk about some of the ways we do it, right? And we don't want to just look at it black and white like traditional healthcare does, right? Because in traditional neurology, they're looking at stroke, no stroke, tumor, no tumor. It's like it's within normal limits. And you see that a lot of times on exams as grossly normal. What does that even? It just means
grossly unremarkable is what mine said.
It just means you're not like you don't have a tumor, but it doesn't mean you're functioning well. And so we look at it from a black and white because we want to make sure that there's not a brain bleed or something serious. And if that looks okay, then it's saying, well, how does it look functionally, right? How is it compared to a healthy individual, you know? And so we have to be able to have ways of looking at that, which we'll talk about. And then we have to have ways to assess blood flow to the brain, which we might talk about. But then also the unfortunate part on the inflammation side is there's no great test to test for brain inflammation, right? Unfortunately, all that's up here. What we can do is we can look at markers of systemic inflammation because we know that body inflammation will in turn affect brain inflammation. So that is one area where I think clinically we still struggle in like quantifying, improving. A lot of it is going off symptoms and how one responds to care, but that's not as easy to quantify as someone's balance or as someone's memory or even blood flow, right? With blood flow, we can look at blood pressure, we can look at heart rate, we can look at it in different positions. There's even some of my colleagues, Dr. Kaiser being one of the main ones, who actually has devices that measure cerebral blood flow, which is really cool. So there's also that ability, which is a little bit easier than saying there's inflammation in your brain. We know that occurs because of research, but clinically it's hard to quantify. So going back to that, when we look at, so I guess to take a step back, if you're going to a doctor for post-concussive symptoms and those things are not being discussed, and or someone is saying, here's one treatment for everyone that fits, you should start saying like, that's a little weird. Like, okay, why is everyone just getting this exercise? Or why is everyone getting just this one treatment or this diet? You can realize where everyone's head injury is different and that you need someone that understands all of those different things. And if we look at subcategorizing head injuries even more, you're now starting to see head injuries being categorized into like vestibular ocular motor, cognitive affective, autonomic, right? And so we kind of have these subcategories of like, how do we fit an individual into it? Is like, hey, a lot of their symptoms seem more vestibular or visual, or a lot of their symptoms seem more autonomic, or maybe they seem more cognitive, where they're having a lot of depression, a lot of memory issues, a lot of mood issues. And you see this. And so that's another big thing we need to do, is be able to categorize patients, because that opens up treatment opportunities that make more sense for that. If you have an individual with a vestibular ocular motor type concussion, and you're only doing cognitive exercises, maybe it will help, but is that the right mechanism for that individual? And so that's where the examination comes into play. And this is where, I can kind of speak for what we do. And I know some of my colleagues do similar work is, so we have different tests. So this is where we'll do a lot of balance testing, a lot of vestibular visual testing. And this gives me a really good picture into some of these brainstem networks, right? So within our brainstem is very much about coordinating reflexes, right? Coordinating eye movements, coordinating balance, coordinating heart rate, blood pressure, right? So some of this testing can give us a window of like, does that network seem to be disrupted? Yes or no. Our cerebellum has a ton to do with coordinating balance, eye movements, mood, emotions. So we have ways of being able to test that. And then we kind of move up the chain. And really, actually, what's kind of cool is when you look at a neurological exam that's taught in school, med school, chiro school, PT school, it's really cool because there's literally tests from the lowest part of the brainstem all the way up to executive function. So some people are like, how do you test all that? It's like, well, that's what your neurologist should be doing. That's what your looks.
And I just want to take a moment to just kind of like talk about that part of it, and how like the stuff you guys do has been around for decades. The technology has improved and changed, but at the core, what you guys are doing has been around forever.
Yeah.
And unfortunately, when you're stuck in the traditional healthcare system, I mean, where do you typically go first after you hit your head? Possibly the ER or your GP or your kid's pediatrician. They all have like an hour of training in brain injury.
Mm-hmm.
You might get to the neurologist, but like you kind of said earlier, they're just here to rule in or out like bad things, right? Like the brain bleed or stroke, but they're not really trained to help you. And that's where functional neurology, I think, shines, because that's all you guys really do. And it's what the basis of your training is like I said, these tools have been around for decades, hundreds and hundreds of years. And like I said, the technology has gotten cooler,
Mm-hmm.
the toys that you use. But at its core, it's been around forever.
Mhm.
And so the fact that, traditional, and don't get me wrong, they can't know everything. Your GP can't do everything. But like the disservice I see is people aren't getting any sort of referrals, you
Mhm.
know, or they're even told, oh no, those people don't go there. That's voodoo,
Well,
So
I think the problem comes down to is it's the paradigm of what do you believe the brain to be? And honestly, still it's changing, but even still this day, there's a lot that believe the brain cannot change. So if you believe that the brain is not plastic and it can't change and it is what it is, well, then of course you would look at an exam and only be concerned if there is gross loss, because then the goal is to diagnose and to name what that condition is. And then, and if there's a treatment, it's a medication, or is it a surgery? And if not, then it's about monitoring. And it's about, okay, you have X disease process. Let's check in every 6 months to a year and let's measure your progress of your Parkinson's and kind of watch your decline. Versus if you look at more and more research showing that the brain is plastic and it does change and it can change at all ages, you might start looking at that same testing but from a different lens, in that,
yeah.
like, oh, this is malleable. Maybe when I do a neurological exam and I look at a reflex, instead of thinking like that's the reflex that will be there the rest of their life, those things change, right? Coordination, the ability for someone to coordinate a movement can change. One's balance
Mhm.
can change. So I think it's a paradigm of how do you look at what you're assessing. So you're assessing the same thing, but I look at it in like, that's a malleable system and let's do things to alter that. So then, once again, it makes looking at the exam far more dynamic versus just what you see a lot of times, like, let me just get through my test so I can say I checked it off and like you're good to go.
Mhm.
So I think it's more the paradigm, and you're starting to see it shift, but unfortunately, still in traditional neurology, there still seems to be a huge like there, I don't know, it just seems slow. And the amount of doctors I still chat with that are still just, it's a very, I don't know, the traditional neurology world is a very bleak field. Like you talk to a lot of medical neurologists, and I would feel that way too if there's nothing you could do, you know,
Yeah.
and that it's very kind of um, depressing when you look at it some ways from the lens of where it's taught of just like you
Mhm.
diagnose, work up, medication, or you observe. Um, and so you can kind of see where I think that burnout becomes. And so then you have patients go, and also to the amount of the lack there of exams that a lot of times is done is like, I ask patients this all the time. Well, what do they do? Did they touch you? Like my actually my brother-in-law had some interesting kind of health stuff, and I won't go into it, but I chatted with him when we went to the doctor. I was like, well, what were the tests they did? Like, did they hit a reflex? Did they shine a light? And it's like you sometimes talk and they're like, oh no, they didn't actually really touch anything. And you're like, well, how can you say it's this that? Like if you didn't go through a thorough exam. And so
Yeah.
uh, I see that far too often, and not just in the traditional route, but all throughout healthcare. And
Yeah.
when you're looking at a brain injury is, or I should say, a concussion, right? We know we have different levels of brain injuries. We have severe, we have mild, we have moderate. When you look more at these concussions that don't equal in hospitalizations or
Mhm.
brain bleeds, they are functional injuries.
Yeah.
Like they are, imaging is going to be normal. And the problem with imaging is a static picture. Unless you're getting DTI or diffuse tensor imaging, um, which gives you a little bit more of a dynamic window, it's just a static picture. It does not tell you at all when you're in Costco and you're under lights what's
Mhm.
happening inside your brain. It
Mhm.
just says, hey, there's a chunk of matter. It's there, but you've no clue if it's functioning. And that's the goal, is you have to put people in those contexts and see how is it failing. and then create a rehab strategy to improve that quality.
And I think that's where the healthcare system is failing us. Like you kind of said earlier, like the neurologist is just going to observe and say, come back in 6 months, 12 months, and observe your decline. Where we know the sooner we can get treatment, the better the outcome, right? I mean, don't get me wrong, you can still get improvement at any point in your journey, but like that's where the healthcare system's failing us. Just come back in 6 months. Well, in those 6 months, you could have been doing this, and this, right? And seeing gains instead of declines.
Mm-hmm. Yeah. So, but I think the positive is with functional neurology, with things like neurooptometry, right? With like Dr. Zielinski and Dr. Trinka, and there's a lot of great people. You are starting to get discipline. So you're getting eye doctors, you're getting PTs, you're getting chiros, MDs are coming along. So like what's really cool is you're seeing it bleed over into other disciplines. And it's really cool because like I said, it's crazy how many neurooptometrists I've talked to. They get a lot of like, people don't like them either. Like a lot of the traditional medical field talks about what they do as voodoo too, which is crazy to me because they do really cool work.
They help people. Like, I mean, I'm
people.
a walking testimonial, right? Like, how can you argue that what you do doesn't work when it worked?
Yeah, and what's really cool too is with neurooptometry, and especially I think functional neurology. What's really cool is and we joke about tech because I'd say functional neurologists love technology and they love spending money on technology, maybe a little too much. But what's cool is it helps to quantify, improve changes, right? It's not just, Amy, you saying, well, I feel better. It's like, well, here's a medical test like a VNG or balance,
right,
or neuropsych testing. And it's like, well, they're not used to that changing. Like if you go to an ENT, they don't really rerun VNGs to see changes. They run a VNG and they say, you got, this inner ear pathology. You have neuronitis, labyrinthitis, you have Meniere's. Okay, well, here's what your life is going to look like, versus what we say is, let's do things to change it. And then let's use the technology to show, look, these things are malleable and they can change. And that's what's really cool. And I think that's what will continue to grow the field and will get more of a following, is proof that there are changes occurring in one's neurology.
So, Dr. Perry, tell us a little bit about what are some of the things you guys actually can do? What are some of the treatment modalities you do to help people who are recovering? And, what does that look like? What does a treatment plan look like with you?
Definitely. So like I said, so step one is kind of an examination. And so our intake exams are anywhere from 2.5 to 3 hours, right? And this is where we're looking at the neurological testing, we're looking at autonomic balance testing, cognitive testing, kind of all of that. And so we take that mixed with a clinical history, and then sometimes also to lab work to start saying, how do we put this person into a category? Are they more of a vestibular ocular motor, cognitive affective? Is this more of an energy issue? Is this more of a neuroinflammatory issue? And so from that point, let's say it is more of a rehabilitative thing. This is where we combine a variety of different things. So we combine a lot of vestibular rehab, cognitive rehab, vision therapy, and then manual therapy and things like that, so that we have actual physical rehabilitation tools to say, well, let's rewire this circuit. So like if an individual has trouble integrating their inner ear and their neck, so every time they turn their head, they fall or they get really dizzy, we will create exercise strategies to try to normalize that connection. So now they get an appropriate reflex or response. And so a lot of times on the rehab side, for individuals that are usually in town in Denver, I usually work with individuals for like a 4 to 6 week period. And I usually see them multiple times a week over that 4 to 6 week period. at that end of that period, I kind of rerun all the testing. Usually I know well before that because I'm checking things every rehab session to see if they're changing. But what we're shooting for is, of course, improving symptoms and quality of life, but I want to see objective changes. So if an individual has poor balance, I want to see that their balance is improving. If their reaction time is slow, I want to see that their reaction time is picking up. And so we're creating rehab programs specifically for their weak areas of their brain. And then we're constantly retesting to make sure that the therapies are improving that quality. For individuals sometimes that are out of state or certain conditions that I think do a little bit better is sometimes we'll do intensives. So we'll do 1 to 2 week long intensives. And this is really cool because the brain works really well when there's a lot of frequency and intensity to it, right? So I always tell patients, like, if we do something like once a week, once every few weeks, it's not going to make changes. Like, you have to be either in the clinic doing things constantly or at home doing things constantly, right? The brain, right? If you think about the brain, the way we make new connections is that you get consistent firing into a pathway, right? And when you look at some of the research around neuroplasticity, it takes a lot of time to actually make new connections, right? So you can get someone feeling better in a few days to a few weeks, but a lot of times if you don't continue to fire those pathways, it would just be a party trick. And in a few weeks, they may revert back, right? And in that case, you didn't make actual plastic changes. So we need to have frequency and intensity to create new connections so that in hopes that this individual down the road doesn't have to be doing exercises, but they're still maintaining the improvement that they made. And so that's kind of one avenue we do. We also have a nurse practitioner and nutritionist where if we sometimes think there's a metabolic issue, this is where sometimes we'll do things with diet. We'll do things with hormones or hormone replacement. We will do different things like IV glutathione or NAD. IV glutathione can sometimes be helpful in quelling brain inflammation. IV NAD can be helpful in improving energetics and things like that. And so if I think that that's more the mechanism, then I work with Dr. Hill, our nurse practitioner, and they may be just working with him. And they may be doing things to work on brain inflammation or working on improving brain endurance with things like NAD or hormones and things like that. So it's a really cool team approach where an individual may be doing a little bit of all that, or they may be doing purely vestibular rehab. Or I have patients where the only thing they're doing is, NAD, where everything looks good. They just don't have a lot of brain endurance. And so at that point, we're working on exercise. So I love exercise, and I think it can be a powerful thing to reinstate energy systems in the brain, right? Using different types of training can be really helpful in getting no different than like an ACL. And right, you need to get the knee moving. You need to load the knee. You need to be able to walk. And then you need to get back to sport-specific activity. If it's basketball, it's cutting, it's jumping. If it's skiing, it's what comes with skiing. And same thing with life, you have to get contextual with someone's rehab. I was talking with a patient today, and they were still having issues with playing tennis. And if all I do is rehab in a clinic against a blank wall, that's not really the context of outside, wind, changes in depth perception, a ball, hand moving. So we really strive to find what are the avenues that individuals wanting to get into and tailor it. This is why cookie cutter concussion protocols only work so well. They'll get people better, but they won't get everyone better, right? And they won't get very difficult cases better. And so that's why you need to be wary if you're going to a place and it's very cookie cutter. And it's just the same for everyone. It's the same exercise. And it's the same rep scheme. It's 5 sets of 10. Like you're aware of is with brain injuries is everyone has different fatigue points. And it needs to be customized towards them. So I would say if there's any red flags to look at, those are the red flags. Is just, I've run into practitioners, and this is probably one of my biggest pet peeves is, and people try to sell me on stuff all the time, is like, hey, you need my technology. you need this tool. I have this tool and it fixes everyone. It fixes every brain injury. I'm like, that's awesome, because I don't fix everyone. So I would love to know what you're doing. And you should be a millionaire if you're fixing every brain injury. And so when you go to an individual and there's one tool, kind of one tool to rule them all, that's also where you want to be a little bit cautious, because not everything works for every traumatic brain injury or concussion. You want someone that's got a vast knowledge with a big toolbox, right? They have hyperbaric. They can do vision therapy. They can do vestibular rehab. They understand functional medicine. That's when you know you're in good hands, because they can understand the whole picture versus just a clinic that does neurofeedback. Neurofeedback's great, nothing against it, but it's not necessarily for everyone.
Right. That alone is not the solution. Right.
No, but for certain cases, it can be a game changer, and it can be exactly what they need. But if that's all you know, how do you know when they don't need your services? That's the key, is how do you know when they don't need you and they need someone else?
All right. Well, Dr. Perry, I'm going to see here now if anyone has any questions. Go ahead, drop them in the comments. I'm trying to read. Okay, let me try reading it out loud. Why can't we have this evidence-based care and medicine for TBI neurology as there is for other medical treatments? My son's cookie cutter rehab was frustrating.
Yeah, that's a great question. And I think it's somewhat the what holds functional neurology back a little bit, because I agree with you. It's hard when you're looking at studying the brain, it's hard sometimes to control for all of these variables. And so I agree, we need more of a push. And this comes from my own profession, is like, we need more research. We need more case studies that drive research. And I think it's coming and it will build, but it's very difficult, right? Because you're talking about the brain, and that's very different than, let's say, a blood marker like cholesterol, right? Or if we're looking at risk factors and we're saying, okay, does this medication improve cardiac outcomes? And we're looking at cholesterol, we are looking at blood pressure, calcium score, whatever it may be. It's just, there's so much of the brain that we still don't understand. I mean, so much of the human body, but I think that's what makes it difficult, but it's building. There is gaining more and more research on things like vision therapy, on things like vestibular therapy, on ketogenic diets, on hyperbaric. So we are getting more data for all these individualized things, but we need more data coming with a model kind of like we do in functional neurology does. And so I think you will get there, but it just takes time. And the other thing is, it takes funding. You need someone that funds these studies, and depending on how much money is to be made, it may not get the funding, or how easy is it to apply? A lot of what we do is not easy to apply. So sometimes it's not always appealing to organizations to fund, because it's difficult to reproduce and it's difficult to make a profit on. Unfortunately, at the end of the day, that's what drives research a lot of times.
Yeah. Well, Dr. Perry, this has been such a great conversation. Perfect topic for March, for Brain Injury Awareness Month. Thank you so much for being here. So just so everyone knows how to find you, you are at Integrated Brain Centers in Denver, Colorado, along with Dr. Shane Stedman. Yep. Your website is integratedbraincenters.com.
Yep.
And if folks want to schedule, they can do a one-on-one phone consultation with you, correct?
Yep. So we offer free 30-minute consults for anyone, in person, phone, Zoom. It allows us to kind of review cases and see if there's something we might be able to do to help, or if there's someone in your area, across the country that could be really helpful for you as well.
Wonderful. Well, thank you so much for being here today. Thank you everyone for watching, and enjoy the rest of Brain Injury Awareness Month.
Thank you so much, Amy.